All right, let's dive right in. If you've got an exam on depressive disorders just around the corner, you are in exactly the right place. Think of this as your rapid review study session. We're going to hit the high-yield facts to really lock this stuff in. So you're cramming for the big test. Hey, we've all been there. We're going to cut right through all the noise and focus on what you actually need to know to ace those questions. No fluff, just the core facts to make it all stick.
Okay, first things first, the core concepts. We have to build our foundation here, right? You're not going to get those complex questions right if you don't have these fundamental terms down cold.
Now, here's a classic distinction I can almost guarantee you'll be tested on: mood versus affect. The easiest way to remember it: mood is the patient's internal climate. It's what they feel inside, sustained over time. Affect is the observable weather. It's what you, as a clinician, actually see on the outside. One is internal, the other is that external expression.
So what exactly are depressive disorders? Well, it's way more than just feeling sad. The key for your exam is knowing that this sad, irritable, or empty mood comes with somatic, physical and cognitive changes that actually get in the way of a person's ability to function day to day.
And that brings us straight to the big one: major depressive disorder, or MDD. You really want to think of this as the prototype for all depressive illnesses. Seriously, if you can master MDD, you're going to have the key to understanding this entire category.
For your exam, you absolutely have to know these diagnostic criteria. It's a two-step process. First, for at least 2 weeks, the patient needs one of the two core symptoms, either a depressed mood or anhedonia. That's the official term for a loss of interest or pleasure. Then, on top of that, they need at least 4 other symptoms from that list. Things like changes in sleep, appetite, energy, you get the idea. This is pure exam gold, so make sure you've got it memorized.
So just how common is MDD? Well, this is a key public health stat you'll want to have in your back pocket. Roughly 7% of Americans experience depression in any given year. It's a simple number, but it's powerful and definitely testable.
But here's the thing, that prevalence isn't spread out evenly. This chart shows a really critical point. MDD is 3 times more common in young adults, we're talking ages 18 to 29, than it is in adults over 60. That's a huge disparity and a key detail for understanding who's most at risk.
Okay, so MDD is our prototype, but it's not the whole story. Now we need to look at the broader depression spectrum. Knowing how to tell these different disorders apart, well, that's going to be essential for all those tricky differential diagnosis questions they love to put on exams.
This table right here is your cheat sheet. It really all comes down to the main feature and the timing. So first, persistent depressive disorder, or dysthymia. The key word is chronic. Think at least 2 years of depressed mood. Next, PMDD is cyclical. The symptoms are tied directly to the last week before menses. And finally, disruptive mood dysregulation disorder is all about early onset and irritability. It starts before age 10 and is defined by these severe temper outbursts.
So, we can diagnose it. Now what do we do? Let's shift gears to treatment and priorities. This part is all about clinical application, what you actually do, and what has to matter most.
And when it comes to treatment, let me be crystal clear. The first priority, the only priority to start with, is safety. Before you think about anything else, meds, therapy, whatever, you must ensure the patient is safe. It is the absolute non-negotiable first step.
And what does ensuring safety mean in practice? Well, it means your immediate next move is to conduct a thorough suicide assessment. You have to evaluate their risk. This is a critical point of care you just cannot afford to miss.
Okay, once safety is established, what are we trying to achieve? There are really 3 main goals with treatment. First, get the symptoms under control. Second, help the person get back to functioning in their life, at work, socially. And third, do everything we can to reduce the chances of it all coming back. It's a whole person approach.
All right, let's talk about medications, because this is where the stakes get incredibly high. This isn't just about picking the right drug. It's about understanding the critical warnings that keep your patients safe.
This right here is the single most important warning you need to memorize: the FDA black box warning. It's a tragic irony, really. The very medications we use to treat depression can sometimes increase the risk of suicidal thoughts, specifically in children, adolescents, and young adults up to age 24. This isn't just a test question, it's a life-or-death clinical reality.
Another critical concept is what happens when a patient suddenly stops their medication. Stopping cold turkey can trigger something called antidepressant discontinuation syndrome, and it comes with a whole bunch of nasty symptoms, including, you guessed it, a potential increase in suicidal thinking. The takeaway is simple but vital. Medication must always be tapered off gradually under supervision.
Okay, we have covered a ton of ground in just a few minutes. We hit diagnosis, key stats, priorities, and those critical warnings. So the question is, are you ready to put it all together and actually apply what you've learned?
Here is a practice essay question to help you synthesize everything. Go ahead and pause here and just see if you can outline a solid answer. Can you clearly explain the differences between these disorders based on what we just went over? Use this to test yourself and really lock in the knowledge. Good luck on your exam.